Thank you for giving me the opportunity to talk about some IPC-related matters. So I'm going to be talking about navigating contact precautions, and we'll just go through the understanding of it and what we can do about it. And this is my outline. So we're going to talk about the types of precautions. I think everyone knows that, but for those that don't, we'll go through it. And then what is the evidence behind contact precautions? How compliant are we as healthcare workers to contact precautions? What are the adverse effects? And that's specifically looking at patients. And then, is there any guidance with regards to discontinuation and also what to do about these multi-drug resistant organisms? Okay, so just to go back to the basics over here. So contact precautions essentially means wearing gloves, apron, having good hand hygiene, whether it's with soap and water or alcohol-based hand rub, it does not matter. And other than C. diff, which will put it in its own category, and these are organisms which which need contact precautions. So MRSA, VRE, vancomycin-resistant enterococcus, CREs, ESBLs, carbapenem-resistant Pseudomonas, and then our good old friend Baumani. So droplet precautions, what should we be doing over here? So we need to be wearing a mask, and in some cases I might even argue and say that you need to wear eye protection as well. And then again, one needs to consider wearing an apron and then good hand hygiene. And these are the organisms that you need to be worried about. And unfortunately, we've had multiple occasions where we've met our friend from diphtheria from Paulsmore. Luckily, we haven't seen any more cases of late. And then Neisseria meningitidis, Bordetella pertussis, yeah, not so much on our side. Influenza, we all know that we're going through quite an increase in the influenza at this point in time, but nothing more than what we have been seeing in the past few years. Yersinia pestis, rubella, and then Mpox. I'm sure people have read on the news about Mpox in Gauteng as well as in KZN, in Addington Hospital. I don't remember which is the other hospital in KZN. So something to think about. And then airborne precautions, I think we're all well aware of this because we see so much of it in our units. So that's mainly TB. We mustn't forget that varicella zoster, as well as measles, also from a virological point of view, highly infectious, and we don't see a lot of it. We do see the odd occasional patient with disseminated VZV, and we mustn't forget that those patients do need airborne precautions, and then we like to forget about SARS-CoV-2 for PTSD-related reasons. And then neutropenic precautions, as I always tell everyone, it's us protecting the patient, but also our neutropenic patients actually do commonly, especially in our units, have multi-drug resistant organisms, but more so it's to protect the patient from us. Okay. Let's get into the nitty-gritty now. So this was a study by Cohen in 2015, which looked at a systematic review of the transmission of multi-drug resistant organisms in an acute care setting. And unfortunately, a lot of these studies unfortunately, a lot of these studies that look at it, there's not, the data behind it is not very good, and in this systematic review, they only looked at 6 studies, and only 2 of them were powered, had power calculations, and overall, the data surrounding the effectiveness of contact precautions is not very good. So you can't say, yes, we should be having contact precautions. No, we shouldn't be having contact precautions. But you see, there's a lot of caveats towards this. And in the study, only 2 of the studies out of the 6 looked at gram negatives, 4 looked at MRSA, and 1 looked at a VRE. And also, we know that there are other means of transmission of organisms, as we've just described through airborne and droplet. Compliance measures were not in these studies were not really looked into, and what tools do they use for compliance is another area, and also the cost of these interventions. As we know, IPC can be a rather cheap strategy to get into to prevent infections, but at the same time, there are some aspects which are costly. And then one-to-one nursing. I mean, even in our ICUs, especially during COVID time, we had very few one-to-one nursing, and especially in our hematopoietic stem cell transplant unit, where in actual fact, there's almost never one-to-one nursing. And then equipment sharing. I mean, think about it. If you go into the G floor ward, you will commonly see the same blood pressure cuff moving between, well, there might be 2 blood pressure cuffs between 32 patients, right? And I'd love to know how many times those blood pressure cuffs are actually cleaned between the patients. And again, those studies don't really look at that. But overall, what this study showed is that a lack of data doesn't mean we shouldn't do it, because by theoretical knowledge, it does work. It should work, sorry.
Sorry, theoretical knowledge. We have multiple, thousands of different outbreaks in wards. So, and there's also the precautionary principle. So, I think there's enough observational data to know that there is transmission in molecules of multi-resistant bacteria.
Yeah, no, sorry, you're correct, and especially with like hand hygiene and decreasing. But I think this was specifically looking at contact precaution, gloves, donning, doffing. But we'll get to a little bit more of it now. I'm going to show you some more studies. So this was a study by Wong in 2022, which looked at an approach to multi-drug resistant organisms in long-term care facilities. And again, it was only mainly powered for MRSA, which we fortunately don't see a lot of in our units. And they looked at the interventions that they try to see which interventions would decrease your MRSA in those long-term care facilities. And they broadly put it into horizontal interventions and vertical. And horizontal interventions included getting administrative buy-in. So that means getting your CEO, COO and medical managers to understand how important it is to have contact precautions for the various units. And then barrier precautions, education. We know education is a very important part of IPC. And then having your environmental health services and cleaning of these isolation rooms, etc., especially once patients have left the units. And then hand hygiene, as we all know, hand hygiene is probably one of the best interventions to try and decrease hospital-acquired infections. And then source control. Now, source control in these long-term care facilities was if a patient had a wound or an abscess, it was describing that one needs to specifically address the source so that you try and decrease the burden of the organisms. So that's the horizontal. Now, vertical interventions were slightly different, and that looked at having active surveillance, okay? And that's what we do over here. We look at the escape organisms, we look at the CREs in the hospitals, etc., and then doing decolonization for these patients. Now, interestingly, again, on this article, they showed that there was no decrease in MRSA colonization with regards to IPC horizontal interventions. Okay, and in actual fact, there was a high reinfection in these patients. And a very old article from 1991 showed that in hemodialysis units, in actual fact, recolonization happens again within 3 to 8 weeks. And that's probably related to the burden of the disease in the units. And I don't know how well these units are generally cleaned between patients. However, the vertical interventions, which we talked about, the decolonization as well as the active surveillance, did, well, potentially show the reduction in the MRSA. But again, there's quite a lot of caveats. Low quality of evidence, few studies looked at a single intervention. And as we know in IPC, everything is multimodal. Okay, very few times in IPC will say, this intervention will decrease your hospital-acquired infections. And we know this because that's why there's bundles of care. Surgical site infections, CLABSIs, the whole bunch. It's not just one intervention, right? And again, lack of adherence towards these interventions. And then a few included multi-drug resistant organisms, and then again, the studies didn't have good compliance to hand hygiene. And we know hand hygiene compliance is bad. In our hospital, it's anything between 25 and 40%. And if you want to decrease hospital-acquired infections in hospital, you actually need a hand hygiene compliance of around 60 to 70% to see the numbers coming down. Okay, this was another study by Dar, but older, 2014. It was a prospective study, and it looked at are contact precautions more necessarily better. And they looked at 11 teaching hospitals and they assessed the compliance to the various components of contact precautions as well as hand hygiene. And this was quite a nice study. I like the study because it talks about the compliance of healthcare workers. And as you can see over here, there were 5 parameters that they looked at, not 5 moments of hand hygiene. All right, hand hygiene before putting on PPE. Was the compliance was only 37%, gowning, seen 74, gloves 80%, doffing was pretty good, 80%. Hand hygiene after leaving the room was seen in 61% of cases. And as we've seen in our data at Pretoria Hospital, most people do good hand hygiene after leaving the patient's bedside. And that's related to the fact that us as healthcare workers don't want to become infected by what the patient has. And in actual fact, hand hygiene compliance before touching the patient is one of the most important aspects of the 5 moments of hand hygiene. And then if you look over here, compliance to all 5 components was sitting at 28%. Now, what was really interesting, and it doesn't make sense, but like if you think about it, then I guess it does. So they also looked at what was the compliance compared to the amount of multi-drug resistant organisms. So if your hospital had less than 20% burden of multi-drug resistant organisms, compliance was sitting at 42%. But the minute it was higher, more than 60%, your compliance went down to 5%. That doesn't make sense, right? Because you would think that if I knew there were a lot of patients in my ward, I've isolated them, I've cohorted them, etc., I'm going to make sure I wear my PPE. But the reason behind this, they think in the article is that it's related to fatigue. Okay? At some point in time, you're just so tired of putting on your contact precautions, because let's not forget, putting on PPE takes time. You've got to see 30 patients, and if you have to do that for 10 of the patients, it takes a lot of time. But,
so how did they divorce the issue of the fact that this burden of MDROs maybe 60%, because contact precautions are badly undertaken, rather than the other way around?
Yeah. No, exactly. I mean, this is one of the limitations, and unfortunately, in all of these studies, there's so many limitations with contact precautions because, as I said, it's multimodal. But how did they? Yeah, I understand what you're saying.
That's not a limitation. That's an interpretation issue.
Yeah.
I mean, they're suggesting that the higher your rates, the lower your contact precautions, because they've got fatigue and nobody wants to do it. But it may be that the higher the burden is because their compliance is just bad. Anyway.
Yeah, could be.
It doesn't tell them that.
Yeah. Well, I still think like it doesn't make sense I can't fathom in my mind that healthcare workers, if they knew they were going to see patients with these resistant organisms, why they wouldn't want to protect themselves. Okay, firstly, because that's people care about themselves, but also protect patients around them. You know, that doesn't really make sense. I really would have thought that percentage the compliance would have been higher. Anyway.
I think they're measuring the wrong thing, Tari.
Yeah, eventually.
Yeah.
Okay, and then this was another article in 2009 looking at the adverse outcomes associated with contact precautions. It's an old study, but I put it up here because I'm going to show you a study which contradicts this. And now, what were the adverse events associated towards the patient with putting them on contact precautions? Now, you can imagine in our unit, we have isolation rooms. And hopefully most of them remain in the isolation rooms. But in the study, they showed that there was a delay in care of these patients and more non-infectious related hazards. Now that included more falls, more pressure ulcers, more electrolyte disorders, and inappropriate documentation of vital signs. And you can say to yourself, "But why does that occur? If I'm a healthcare worker, it's going to take me time to move into the units and turn the patient. I also am not going to hear the bell ringing that to tell me that the fluid is finished on the drug because I've closed the door. Maybe the patient's got airborne precautions as well. All right. And then inappropriate documentation. Well, now I have to move in. I have to take my BP cup. I have to go into the room. I have to put the BP cup on the patient, then move out of the room and then clean the BP cup, etc. So there's a lot of caveats, a lot of movement and time that needs to be taken. And then less patient healthcare work time. I mean, you can imagine in C15 when we go into the TB isolation, I know it's airborne, but many people don't want to go inside because it takes time to go see those patients. You'd rather just read the notes and say, okay, patient has this problem, great. Look at the X-ray, right, neck notes, let's carry on. And in this one, they showed that there was increased depression and anxiety in patients. And anecdotally, I've noticed that. I cannot tell you how many times I've walked through the wards and I've closed doors, and then I come back half an hour later and the doors open. And that's not the fault of the doctors or the nurses, it's that the patient opens the door. And I say to them, why, please close the door? And then they're like, no, but I want to see people. Yeah? Being isolated the whole time is not very nice. You know, being in this room and all you see is the ceiling. Right? And then patient dissatisfaction was also noted. Okay, the caveats again, a lot of methodologically weak criteria, observational studies, lack of control groups, etc., etc. Okay, this was the study that I also wanted to look into, which contradicts that one. So it was in 2022, again looking at the adverse events associated with patient isolation. It was quite a big study. They looked at 19 studies, multiple sites, unfortunately retrospective, and it makes sense that it was in the general medicine wards. It was done over an 12-year period, and overall, they found no statistically significant difference in adverse events in those patients that were isolated versus those that were not isolated. Okay, and this is the forest plot, which shows the adverse effects specifically related to clinical care. And you can say there's a tendency towards increased adverse events because of the diamond over here, but as you can see, it's very wide. And furthermore, it crosses one. And already 3 of the studies are crossing one. And the Lavorsi article has got a massive confidence interval. So, you know, how much does it actually, how much increase is there of adverse events? Okay. Then this is looking at the patient-related experience, and in actual fact, again, nothing to go home about. Forest plot crosses the one. So, is it a problem? I don't know, but as I said, anecdotally, from working in the wards, I see this as an issue.
So we've got two systematic reviews looking at small numbers of papers. How much overlap was there between the two studies?
No, so one was in 2009,
Yeah.
the first one, and
Well, I
then
understand
the next one was over 2009 to 2020. So it's they commented on the first article and said that we found something completely different.
And what are the numbers, the sheer numbers in these studies in the new one?
I don't remember, sorry.
I mean, are they very, usually confidence intervals are very wide if they're very small numbers. So, I mean, and what is the risk of bias within each of the studies? Because if they're very high risk of bias, then that's difficult to interpret. It doesn't really tell you, you don't know if it really tells you.
Yeah, thanks. Okay, this was a policy which came out recently, I don't remember the date, I think it was 3 or 4 years ago, by the Israeli Ministry of Health. And the reason why they brought out this policy was to try and decrease CRE carriers in the hospitals. And they wanted to look at the impact on isolation days, as well as the amount of patients that had new acquisition of these CRE organisms. Okay, so the methodology, it was a retrospective study done between 2010 and 2017. It was done with 4-point prevalence surveys, and 887 patients were assessed. All the patients that were admitted to the hospitals had an entry swab looking for CRE, so rectal swab in these cases. And if they were colonized, they was, if they were CRE colonized, then what they did is they repeated the swabs 3 months later, a week apart, 2 swabs, okay, because of the intermittent shedding, etc., to see if they are still CRE colonized. And they obviously did culture and PCR to look for those CREs. And if the swab at 3 months was negative, then those patients were de-isolated and were allowed to go into the open wards. And what they showed over here, so if you look over here, I guess the y-axis is the years, and the x-axis is rate per 10,000 patients, and then on the other side, it's the amount of isolation days. So if you look at the amount of isolation days, one can see that we're looking at this axis over here now. Over time, the amount of isolation days decreased, and furthermore, if we look at the acquisition per 10,000 patients, not much of a difference over time. Say maybe from 5 to 4 per 10,000, and then again, sorry, this is acquisition. Sorry, from 3 to about 1 per 10,000, and they found that there was less CRE acquisition, and that was related to good surveillance, as well as efforts to de-isolate or to isolate patients as soon as possible. And they saw obviously a decrease in the amount of CRE cases, but what was interesting is that the CRE acquisition was still, with relapse, was still sitting at 25% over after 1 year, within 1 year, and then if it was more than a year later, the relapse was sitting at around 10%. This was another study which was in 2016, looking at the decolonization strategies for these ESBLs, these CREs. It was a systematic review and a meta-analysis. And they assessed 37 studies. They looked at, again, ESBL CREs, and they compared the colonization in the acute care setting, as well as the colonization in the community, and then the effect of decolonization therapy. So I'm going to go into each of those aspects on separate slides. All right. So what this slide is showing is that colonization decreased with time. Okay, but this is without any intervention, and this is in acute care hospitals. So as you can see, after a month, colonization was still sitting at 76% of those that were originally found. And after 6 months, you're sitting at 55%. Now, if you compare it to this community residents, the amount of ESBL CRE colonization decreased much more than the other group over there. And this one went from 52 to 19%, again, without any intervention. And this might be related to the fact that if patients are in and out of hospital, they keep on getting exposed to it. Whereas hopefully in the community residents, there's less exposure.
Sorry, Tari, but one in the hospital. So there's different patients.
No, it's the same. They follow them up.
Same patients that happen to come in at the open months.
Yeah. And that's why they're able to say that the colonization with CRE managed went from 76% to 35% after 12 months in those patients. They followed them up. Okay, the decolonization methods that they used was interesting in all of these studies, and what you can see is they use gentamicin, colistin, and even cefotaxime over here. And in some cases, actually resistance did pop up. 3.7% of cases were colistin resistant in this article, and 32.5% in this article we had aminoglycoside resistance. And what was also interesting is that colonization at the end of this decolonization that they did was at 36%, but then when they went back and looked at those patients after 1 month, their colonization went back up to 57%. Now, is that because you're stopping with decolonization, or is that because these patients are still in hospital or still exposed, et cetera, et cetera? Okay, and this is exactly what I was saying. So at the end of treatment, there was a significant decrease in the amount of patients that remained colonized with these multi-drug resistant organisms. But at 1 month, as you can see, it favors the decolonization, but once again, it crosses the 1 line. So decolonization works in the acute care setting, according to this article here.
Extremely small numbers.
Yeah. No, again, I mean, look, 25, 19, 27, 16, 23, small. But we'll get into another study, which I'll show you in a little bit. And this talks about, this was an article which is expert guidance. It's a little bit old, in 2018, and talks about duration of contact precautions. I've included it because I think it just gives some guidance towards how should we be following up these patients. And for MRSA, we know that you want to look at the nose, and you want to do 1 to 3 specimens a week apart to make sure that the patient is no longer colonized. And optimally, you're looking at about 6 months before the patient's own flora takes over, and you're not going to pick up the MRSA. For VREs, again, 1 to 3 specimens. Unfortunately, it's a bit more difficult to get rid of your VRE, and again, it's going to be invasive specimens, it's rectal or stool samples. And in this article, they recommend that those patients that are immunosuppressed, hematopoietic stem cell, patients on broad spectrum antibiotic burns, etc., should actually remain on contact precautions longer. And then ESBL, CRE, same story again, 1 to 3 specimens. It's the issue about intermittent shedding. And again, these patients should only be de-isolated once it's safe to do so. And that basically means that patients are no longer on broad spectrum antibiotics. They no longer have chronic draining wounds. And you're not in an outbreak. Okay, this is the article I really like, because I didn't really know much about this until recently. It's done in 2019. It's essentially an opinion piece, but Professor Wong is quite well known for his MRSA decolonization strategies. And I would recommend people to go and have a read of this. And he basically describes the who, what, where, when approach to this and why. So who should we, sorry, what can we use for decolonization? And what should you be using is your CHD, so chlorhexidine gluconate, all right? What's nice about that is that it maintains its effects for up to 24 hours compared to with regular soap or patients that have, or even alcohol-based hand rub. Now, there are some caveats to this, and if you're going to do this properly, you need to make sure that you're using 4% chlorhexidine gluconate for showering, okay? And you need to make sure that you lather it and rinse, and the reason being is because of the rinsing off, you want to use a slightly higher concentration. Whereas if you're bathing, and this is bed bathing now, all right, we're going to be using a cloth. So you're going to be using a cloth, and you're going to be leaving it on. And the reason why you're going to be leaving it on is that it maintains an effect for longer, which we've already described, the 24-hour story. But also, it's actually well tolerated. Now, previously, people would say that it's quite irritating towards the skin. But in this opinion piece, his feeling was it's only found in 2% of cases to develop skin reactions to this. So now we know what to use. how should we be using it? Now, this is quite important. I've highlighted a few things that need to be done. You have to thoroughly massage it in. Okay, you need to make sure you get rid of all the dirt, the grime, etc. And I think we kind of miss certain areas of our bodies or of our patients, and that's the neck, okay, as well as back of the knee, between fingers and toes, etc. All right. And then for bed baths, you actually want to use non-cotton cloths because it's something to do with the cotton cloth that doesn't work well with CHD. Sorry, I can't remember the exact thing. And then showering, we've already described the mesh sponge. And importantly, if you're going to use the CHG, you need to make sure that any skin lotion that you put on the patient afterwards doesn't interact with the CHG. And then the skin entry points, okay, this is important because what sometimes happens is because the patient's got a open wound or open abdomen, we don't clean around those areas properly because it's painful. So ideally you need to give your patient morphine or something before you clean them, because those are actually the areas that you should be cleaning the most. And then let's not forget our perineum and that's fine. And then nasal decolonization is very important for MRSA. Okay, not only doing CHD, you're not going to be putting up CHG in someone's nose. So for those cases, you need to be giving the patients mupirocin as well. Okay, now who should we be doing it for? So we can do targeted decolonization specifically for those patients that have recurrent skin and soft tissue infections. And I remember a few years ago we had a young gentleman who had myasthenia gravis and over about 2 years had significant skin and soft tissue infections with abscesses and carbuncles and furuncles with MRSA, and we managed to decolonize him. But the decolonization process, which we did, took a very long time. We did it over 6 months, and unfortunately in those cases you also have to decolonize the family members because there's the ping pong effect. So if Fiona and I are living in the same house, Fiona decolonizes her, but I'm still colonized with it, then I just pass it back on to Fiona. And this is the issue. And then also one needs to take into account what you do with your cats and your dogs. You know, I don't know if I'm going to decolonize my cat and my dog every single day with CHD. I don't think my dog personally wouldn't be very happy with that. I know that from experience. Yeah, I have got so the other thing is to do to target decolonization for primary prevention, and we already know that. There are studies showing that it does work for patients that in orthopedic patients, and also those patients that go for cardiothoracic interventions. And we not recently, a few months ago, we had an MRSA outbreak in our cardiothoracic unit, where we have 4 patients with MRSA. And it makes you wonder if we should be screening those patients, but we'll get to that now. I don't think in our unit it's that important.
Sorry, I thought cardiothoracic surgery was one of the indications for MRSA decolonization.
It is.
It improves outcome.
It is, yeah, that's what I was saying. It's the orthopedic and cardiothoracics it does, but in our circumstance, our isolates, as far as I remember, is we only have less than 5% of patients of isolates in Curtis Care Hospital have MRSA. Now, if we're going to be swabbing every single patient that comes into our D24 unit, is the cost benefits going to be there? I'm not sure. I don't know. Do you guys know how much it costs for a swab?
Do you want to be swabbed?
Me?
Yeah.
Well,
Or going for cardiothoracic surgery.
well, as long as you're not doing a brain box, yes.
And it improves the outcome.
Yeah.
I mean, there's proof. There's trial evidence. That's why they're in the WHO document on surgical site infections. That's the indication.
Yeah. No, 100%, Mark. I mean, if we were in a private setting, I would not hesitate to say we should be screening all these patients. But in the time of where we don't have enough money at the hospital, I mean, it would be nice to do a study on this, but I don't know if we've got enough money to be doing swabs on every single patient. But I agree with you.
I think there are times to save money, areas to save money, and areas to not. I mean, there's evidence base for an intervention which is not that expensive. swab, which is not that expensive, go for it. Current.
Sorry, just one question, is there a threshold over which we should be considering this intervention for MRSA? Because you're saying we've got 5%, and I thought you were implying that it's low, that it shouldn't be. Is there a threshold or I don't know how much?
I don't know what the actual percentage threshold is, but in the areas where these studies have been done, it's mainly it's been in areas where there is community, there's more community transmission of MRSA than what we see. So I don't know if anyone knows what the threshold is. Okay, and then what about universal decolonization for primary prevention? So what about your patients who have MDROs in non-critical areas with medical devices? If I'm not mistaken, in our ICU, fluorescein daily baths are done for the patients, okay? And that intervention is also noted to decrease hospital-acquired infections in ICUs, but I'm talking specifically about doing it in non-critical areas over here. And what about doing them in nursing homes? So, where should we be doing it? And this is from the article, but I think it's quite pertinent to us as well, is what about our bone marrow transplant patients? So what our units have been doing is when patients go for their transplant, a week before or a few days before, they have an insertion of an Hickman line, which is done here at the hospital. And the reason why it's done that, and then the patient is discharged, comes back in a week and gets admitted. And the reason why it's done that is to save time and to book slots and so forth. Now, I'm wondering if we shouldn't be trying to do decolonization on these type of patients, because as we know in our hematopoietic stem cell transplant units, we do see CREs and ESBLs often, and trying to decrease the bioburden, something to consider. What about our oncological patients? Same as the hematopoietic, they're neutropenic, they're on chemotherapy, etc., etc. And then our perioperative patients, pre and post-op. We see a lot of surgical site infections, and I wonder if we know if patients are going to be going for surgery, if we should be giving them their chlorhexidine bath, and their chlorhexidine bottle, and tell them for 5 days before you come for your surgery, go have a bath with chlorhexidine every day, right? And in saying that, there is definitely data which shows that patients before going through any surgery should at least have a chlorhexidine bath the day before or the day of the surgery, to decrease the bioburden. And if you don't have chlorhexidine, then at least soak it in water. And then what about our patients? Okay? Think about our hematopoietic stem cell transplant patients. They get discharged with their CRE, they get followed up very often in our E5 unit, and that's because they require intense monitoring and continued chemotherapy. And they go back and they sit in the open area. But as far as I know now, is they've changed that to the point where there is, when they know these CRE colonized patients are coming back to follow up, they will place them in a separate room and see them separately from the rest of the patients, which I think is a good way of trying to mitigate spread of CREs or ASBLs in the other patients. Okay, now this was a nice article. It was in 2023 looking at decolonization in a nursing home. It was a very big study. It was 28,000 patients, if I remember correctly. And it was called the PROTECT trial. And what they basically did is they had two groups. So routine care, routine washing, regular bathing or showering of the patients, compared to the other group, which had decolonization, which was chlorhexidine gluconate, plus povidone iodine 10%. And that was used as a nasal decolonization technique. And what they did is the povidone iodine was given for 5 days, BD, every other week. And this was continued throughout the stay of patients in the nursing home. And their outcome was looking at the amount of patients that were then transferred from the nursing care home to the acute care hospitals. And prior to the intervention, you can see the baseline was percentage of residents which were transferred due to infection to the hospital, 62, and then when the intervention period came in, that to drop down to 52% compared to the control arm of routine care, which was 62%. Okay, now what about resistance? Okay, so I've already described the other article which described decolonization using colistin, aminoglycosides, cephalosporins, but what about resistance to CHG? Okay, so the MIC for MRSA sits at around 8. That's ideally combined with the nasal decolonization, and the MIC for wild type gram-negative sits at about 32 to 300. And in actual fact, there's not much resistance that's coming through, because if you do it properly, as I've already mentioned, by doing this correctly, then your MICs are very high with the CHD, 20,000 for 2%, 40,000 for 4%. So in actual fact, it's a pretty good and pretty cheap way of trying to prevent infections, and also obviously helps with good antimicrobial stewardship principles. Okay, then in conclusion, what should we do? So I've already said to you the data surrounding contact precautions is a little bit the data is not robust enough, but I really truly believe that we should still maintain contact precautions as we always have been.